Good morning. My name is Katlyn Burr, and I'm the Director of Respiratory Care and Sleep Medicine at Nemours Children's Health, the Nemours Children's Hospital in Delaware. And I'm so excited to share some of this work with you this morning. But before we jump in, I just want to give a shout out to all of our co-authors, Carl Hinkson, Brian Smith, Karsten Roberts, Shauna Strickland, Cheryl Hoer, Kyle Redder, and Andrew Miller. This really was a collaborative work, and I was blessed to be able to be a part of it with this great group of RTs. From a disclosure standpoint, I am a contract trainer for Hillrom, but there are no other disclosures to report for today's topics. And from a background perspective, we'll jump right in. I think everyone is aware that burnout is prevalent and it has been increased throughout the COVID-19 pandemic, but some prior research shows us that 71% of nurses and 58% of providers are currently suffering from burnout. In prior research that was done by Miller, 79% of respiratory therapists were shown to have burnout, and those effects from burnout extend from the individual to the organization and actually reach the patient bedside in terms of patient care and outcomes. So burnout and staff well-being has been previously shown to be affected by leadership, specifically in RTs. Prior data suggests that poor leadership has been a driver of RT burnout, and that's really displayed in a variety of ways, but most commonly increased anxiety, depression, drug and alcohol use, cardiovascular problems, and time off work. And in this research here, we aim to identify factors associated with a positive or negative view of leadership perception. In terms of methods, this was a post-hoc analysis of an IRB-exempt survey that was administered to 26 centers. RT department leadership distributed the survey and sent reminders to their teams. So if you completed this survey or you sent out those reminders on the survey's behalf, thank you so much for taking the time to do that. That survey included hospital center demographics, information about staffing, COVID-19 exposure, leadership, emotional exhaustion, and demographics. There was a 5-item score scale that measured personal burnout and a singular question to evaluate burnout climate, in addition to a validated survey to evaluate leadership. Survey questions include some of these. So there's a Likert scale here, strongly agree to strongly disagree. Respondents were also able to opt out, not applicable, prefer not to answer. And those questions were, my department director or manager is available at predictable times. They make time to give me positive feedback. They give me feedback about my job performance, and they provide me useful feedback about my job performance. So from a results perspective, there were 1,080 respondents, and that was a response rate of 37%. Overall, 66% had a positive view of respiratory leadership, so a majority of RTs felt that their RT leaders were doing a great job. 73% who had a positive view were burned out, versus 91% had a negative view who were burned out, and that was statistically significant. Factors associated with that positive view of leadership include associates who had adequate staffing, were able to complete all their work, if they had basically good answers to the individual leadership or burnout questions, overall burnout climate. If you were in a leadership position and you answered this survey, you had a more positive view of leadership. If you worked fewer hours in the ICU, worked in a center affiliated with a medical school, worked a day shift, were less likely to care for adult patients, or if you were male. There were no differences in leadership perception for the percentage of COVID-19 exposure, if you missed work due to illness, based on your highest degree earned, no difference in leadership perception based on the years you worked as an RT, the hours you worked per week, the hours you worked in the ICU, based on your commute time, race, or the use of RT protocols. Those associated with a positive view of leadership were actually direct care to COVID-19 patients, and factors associated with a negative view of RT leadership were those associates who had inadequate RT staffing, if you were a staff therapist, if you missed work for any reason, or the burnout environment or score. Again, those non-significant factors included some of the same ones from the prior slide there. And then in conclusion, most RTs had a positive perception of their leadership, but negative perceptions of leadership was associated with higher burnout in RTs. And that really related to inadequate staffing, being a staff RT, overall burnout environment, and missed work. RT leadership really should focus on employee well-being on the burnout reduction practices. And I'm happy to answer any questions that anyone has today about this work. I know we probably also have a few co-authors on as well, so if anyone wants to jump in, feel free, but otherwise, thanks so much for being here.